So, dear all, this is a new episode of the ESD School channel about one very important thing in ESD, which is to deal with the specimen and to choose the best strategy for the patient after the resection, depending on the histological result. So, we will discuss today about the multidisciplinary team discussion for superficial tumors. Why and how should we organize it? Or at least an example of organization we have chosen in our unit. So first, in the process of dealing and managing a patient with superficial digestive neoplasia, at the beginning you will have an endoscopy for symptoms or for screening. There is the detection process to find the lesion, a characterization process to try to predict histology and choose the treatment, the resection strategy you choose, the histology examination, and then the MDT, which is this meeting that will try to combine the history of the patient, the risk of additional adjuvant therapy, and the histology to choose the best option for each patient. So first, in France at least, MDT should be multidisciplinary. It's legally something which is necessary. We need an oncologist, and if possible with a specific knowledge in superficial tumors. The people who have done the resection, the endoscopist should be here. The pathologist is here also. If possible, a surgeon should be present in the MDT legally. And if possible, we will also ask to the anesthesiologist, the radiotherapist, the radiologist, if there is a radiological checkup, and oncogeriatre, also if possible, if the patient is old with many comorbidities. So, front of this panel of different people and different specialists, we will present the patient case. And in France, it is legal to have somebody who present the patient, who knows the patient. So we need to have a physician in the MDT who know personally the patient. It means it has been seen physically by one of the physicians in the MDT. And sometimes we have external demands of reviewing, for example, the histology of a resection. In this case, during the multidisciplinary team, virtually or in presential, in face-to-face, we need to have a physician who knows the patient during the MDT to present the case. So we will present the journey of the MDT. Each case will be presented by one physician who knows the patient with the history. The endoscopy pictures are presented blindly from the histology. If needed, the US endoscopy and how the resection was performed, the result of the resection. After prediction blindly of the histology by all the endoscopists present to have a kind of pedagogic exercise, trying to predict indirect the histology of the lesion without knowing the result from the pathologist, we will present the pathology picture by the pathologist, explaining the histology, the minimal criteria of this histology examination. After this, we will discuss again about our prediction, why we did a mistake, why we could be more precise, etc. We will discuss the curativeness of the resection according to the guidelines, but we will take into account the patient context and the risk, and then we will do propositions. The option 1, if there is no debate, for example, and sometimes option 1 and option 2, depending on the situation, on the comorbidities. And we will not forget from this proposition the follow-up after, the surveillance, and also the family screening for next steps. And also, if there are research protocols, in which protocol the patient can be included. So first, to present the case, we need minimal information. the patient age and sex, the size of the patient, the weight, the BMI, the history about previous surgeries, radiation therapy, other cancers before, treatments ongoing that could change the operability or the procedure we should do. Operability will be discussed with cardiac or vascular disease, respiratory problem, anesthesiology difficulties, and oncogeriatre if possible. The patient choice will be also taken into account if it is possible to discuss with him before the MDT. What is the opinion? Is it pro-surgery or pro-surveillance? And we will try to do the proposition according to the patient choice with different options. The first one should be surgery, for example, but if the patient refuses, the risk is not so high, so surveillance could be an alternative, for example. The comorbidities will be discussed. We know that surgery is depending on comorbidities, nutritional status, age, cardiovascular disease, respiratory state, previous surgeries, radiation therapy. A French study, which is quite old, so probably it could be discussed, but it's the one my surgeon colleague in my hospital proposed during this lecture that we did together previously. This analysis of the French surgery for colorectal lesion had a mortality of 2.9% at 30 days, with some risk criteria like emergency surgeries, denutrition, age over 70 years old, and neurologic disease. We know also that the risk is also linked to the technique itself. So if we can do laparoscopy, it's probably less morbid than a conventional laparotomy. The global morbidity of surgery for colorectal disease for colorectal surgery in France was 35%, with 4.4% of fistulas and 4.5% of stoma. And then again, there are risks. For example, the particular risk for cirrhotic patients have been analyzed. And the risk of stoma, for example, in case of alcohol consumption was 7. And tips before surgery can lead to better results. So should be, for example, considered before a surgery for a colorectal cancer in patients with cirrhosis. Second step, we will show the endoscopy picture, and I choose this case, which is a lesion in a patient with previous history of radiation therapy for prostate cancer. Really at risk because of comorbidities. He had also a liver disease, a chronic liver disease. He was almost against any surgery. So despite the aspect of invasive pattern with amorphous mucosal pattern and avascular areas, the size of this area was around 12 millimeter. It goes into the cap. So we decided to perform a resection. But because it was a rectum, we did an intermuscular resection in order to increase our chance of being R0 on the deep margin, or the deep vertical margin of this lesion. So we did an intermuscular resection. Here it is just a representation of the resection to understand why intermuscular resection can lead to better R0 rate than endoscopic submucosal dissection in these borderline tumors with a high risk of being a T1 cancer. Instead of dissecting into the submucosal space, we will try to reach the intermuscular space. It means the space which exists in the rectum between the circular layer and the longitudinal layer. It's possible to inject this layer, and then you can therefore have a dissection that take all the muscle and have a better R0 resection rate for this. So after we will have the histology picture and the histology description with a minimal information about the lesion. The organ will be very important because, for example, in the stomach or in the esophagus, we have not the same cutoff than in the colon. A precise location will be very important because surgery of the rectum is not the same as the right colon, for example. The histologic subtype, is it an adenocarcinoma, a squamous cell carcinoma? Is there independent signet ring cell, for example? We need the invasion depth, intramucosal, T1, T2, depth measurement in microns and error margins. The resection quality is important, R0 or R1. The vertical margin, horizontal margin, new cut if needed to have a precise assessment of the deepest point, and the inclusion process. Pejorative criteria should be described also, like lymphovascular invasion, venous invasion, nerves invasion, undifferentiated component, and budding. How the pathologist will deal with the specimen. These slides come from Tanguy Fenouil, our pathologist, who give me this. They will use inking with different ink on the edges and under. And we will have a yellow one, for example, for the lateral margin to be sure we are in the lateral side of the lesion, and a green one at the bottom to know where is the depth of the resection and to measure the maximal depth of invasion and the minimal margin of resection between the deepest point and the margin of resection. He will also describe the macroscopic management of the specimen, showing the wool cancer and measuring the wideness of the invasion component and the depth of submucosal invasion. In this case, we had a low-grade adenocarcinoma with no lymphovascular invasion, no neuronal invasion, no budding, and only the criteria of depth of submucosal invasion with 2,400 microns. And the margins were okay vertically and horizontally. So finally, it was a T1 cancer with only one pejorative criteria, that was depth of invasion over 1,000 microns. So in this case, we discussed with the endoscopy picture, histology picture, and the result of histology, the curativeness depending on the patient context and risks. Here we have a T1 cancer with only depth of invasion as a criteria, and we don't know exactly the clear risk of lymph node metastasis and recurrence, relapse of the patient in the future. The literature is very, very spread out on the risk. Some studies say very few risk, 2.2%, some 16%. Some say that it's not an independent risk factor. Some say that it is an independent risk factor. And finally, we don't know. Fortunately, a study came. Yeah. A recent study from the Netherlands with a meta-analysis of 65 studies with 21,000 patients lead to an analysis of 1,080 patients with only depth of invasion over 1,000 microns, and they concluded that the depth of invasion was not an independent risk factor with a risk of LNM of 2.6%. But it is really not sure that depth is not an independent risk factor, as recently demonstrated in Japan with 10% in the series from Tsuji in digestive endoscopy this year. And in our study, which is now submitted, with 219 patients with T1 cancer with more than 1,000 microns, but no other pejorative factors, we had 13% of lymph node metastasis evolution. So, despite the fact that this meta-analysis seems to show that depth of invasion is not really an independent risk factor, practically in our patients, the risk of lymph node metastasis in case of depth of invasion over 1,000 microns is over 10%, and is difficult to accept to propose a follow-up for such a risk of invasion. Furthermore, Saito in 2015 showed that if you have a relapse after a cancer T1 resection by endoscopy, the risk of death is 54%. So probably recurrence is difficult to deal with, and to treating the patient curatively at this time is not so easy, even if this study is relatively old and should be adapted to recent chemotherapy. So, for example, in this case, we propose this conclusion. We have a complete endoscopic resection of a deep T1 adenocarcinoma without lymphovascular invasion, only with a depth over 1,000 microns, with a risk of lymph node metastasis in between 3-4% if we use a Netherlands study, 10% if we use Japanese one. So, we will propose in this case an extension workup to detect metastasis, and after, an informed discussion should be held with the patient to discuss between surgery systematically or with surveillance, depending on the risk of each patient. And it is in accordance with the French guidelines about cancer management. So finally, we will lead to a proposition. This proposition will take the standard conclusion, which is the common conclusion we do for each situation, but we will adapt it to the patient. So for example, in this patient with an history of radiation therapy, with a very high risk of surgery, we will probably put the conclusion of a proposition of surveillance a little more clear than if the patient is 40 years old and if we want to propose surgery as a first option. So if it is a young patient without comorbidities, we will say surgery is the common option chosen for the lesion with more than 1,000 microns. But if the patient refuses, we will propose, for example, a surveillance. And if the comorbidities are very high, we will more say the choice between surveillance and surgery should be taken according to the comorbidities and after discussion with a surgeon evaluating the risk of the procedure. So really, this is the aim of this MDT, is to adapt a conclusion coming from science and literature to a patient with his own risk and his own comorbidities. And after this conclusion, we will announce the result to the patient clearly, fairly. We will address the letters to our correspondent, so the GP of the patient, the oncologist, the endoscopist who send the patient. We will refer the patient to the good next physician. Is it an oncologist, a surgeon, a radiotherapist? Over. We will propose the endoscopy follow-up rhythm. And we will propose also the familial screening, who is considered by the screening, at what age, and what is the frequency, the rhythm of the surveillance. Here we will show an example. It's a sigmoid lesion, that was resected by ESD. The specimen was analyzed. Our pathologist marked the lesion to have an optimal evaluation of the risk criteria. They found a lymphovascular invasion in this case with an embol, which is not very clear here. but we will see it thanks to the immunochemistry. So it allows to detect more precisely the embols and also to detect the budding. But in guidelines currently, the count of budding should be done in HES and not using immunochemistry to reduce the risk of overgrading the budding. So immunochemistry is used for every time to detect budding, but to count it, they should use HES as previously done. And the significant budding is described by more than 4 buds, so at least 5 per field of view. Here, so in this case with significant budding, the literature is quite clear and it seems that the risk is high. But once again, if we have budding and less than 1000 microns, the risk is probably not so high, and budding should be considered as a very high risk criteria when depth of invasion is over 1000 microns. So we need again literature to know better the significance of budding for the lesion with shallow invasion in the submucosa. So in this case, the conclusion was low-grade cancer, LVI, high-grade budding, 2600 microns of invasion in the submucosa. In this case, with many risk factors, surgery was the good option that was proposed to the patient after an extension checkup. So thank you very much for your attention. I hope it was useful for you to see how we deal with the MDT situation in our unit. Really inspired by what we saw in Japan in National Cancer Center in the unit of Yutaka Saito. So we brought back this idea of seeing the pictures of endoscopy blindly to discuss the prediction, then seeing the pathology result, and then discussing together why we did a mistake, how we can improve our characterization skill. But nevertheless, the decision at the end is done by the patient, and we only propose an attitude, a treatment strategy, and we try to adapt this proposition to the patient, his comorbidities, also his choice, and to be as much as possible centered on the patient to choose the best option for each individual. Thank you very much.